I think you've. Well, that was a fantastic talk. Thank you so much. I have a question regarding implementing a lot of these efforts. Obviously, trying to trying to pay for current the current risk reducing therapies that are here and are emerging is a Herculean efforts. Sounds like there's significant approaches from the government standpoint for that payer. How about private payers? For a private payer, a GLP-1 agonist is something they may not derive benefit from an outcome standpoint, right? That patient may be on a different payer in 2 years or 3 years. And so they frequently won't want to cost something that we know will impact their even intermediate term outcomes. Have you guys started efforts with individual payers to try to improve, one, educate them on the value of this, and two, maybe from a regulatory standpoint, try to ensure that there's some basic guidelines they're following to deny?
Yeah, I think this is an important point. So I think there's a couple different things. So first of all, it's a complex challenge because, as you're right, there's differing incentives. And at the end of the day, they're just basically looking at bottom lines. They're doing simple math. They're doing simple calculations. And at the end, so there are, if you're the government or if you're a capitated system, it's a very different than if you're a private payer. It's like, look, I'm not going to see this here anytime soon. And if you go to, for example, the SELECT trial, which is a really fantastic, it was a really exciting study, it still translates likely into, at current list prices, about $1 million for one cardiovascular death, right? That is not exciting to anybody, right? So at the end of the day, there's multiple issues here. One is the question broadly of value. So I think that it's likely the case at current list prices, they're not of high value. Salim and I were on the 2018 cholesterol guidelines where PCSK9 inhibitors had just come out, and we were very clear about the fact that these are effective, but they're probably not high value right now. And actually saying that actually makes a difference and can sometimes impact things. Then there's a broader question of broader negotiations, and so you can see that a lot of the CKM therapies are starting to creep into the discussion for negotiations with the government, and that's been a part of several recent actions. There's going to be a push for sure, even further, for these obesity therapies to be a part of that discussion as well. And then the question is going to be, if you get these covered, what do you do? First of all, how do we prioritize that? And then what do we do in the long term? The maintenance is going to be something that needs to be figured out because we know stopping the therapies, things kind of go right back to where they were previously. So is it better to find some intermediate approach? Is stopping it or and having been on it for some period of time sufficient? So there's a lot of work going on in this area, and I think this is a key topic area. But no question, it's a high focus of all of these advocacy efforts.
Dr. Rogers?
Well, I have a question for all three of you. So I think that we have tried today to build a very compelling argument for the importance of cardiometabolic kidney disease in our communities and its impact on the people we see, our community members, on the cost of healthcare. I think we've linked in this really critical part about the importance of the social drivers of health. And we also heard from the health department that it's sort of this particular issue doesn't seem to sort of rise to the level that would need to be at a governmental level to be a focus of, of a health department. So how do we begin to change the infrastructure in our communities to really begin to address some of these social drivers of health that we have established today are critically important to this condition?
Sure. I've given this a lot of thought. I think it's a really hard question. I think that, employers are not the one who will take over healthcare, nor should they, or social services. I think our social services are strapped for funding. I think it is going to take, like you say, a restructuring. So maybe it is a societal understanding of the expense of these underlying conditions and these drivers of health. and it's going to take, you know, perhaps just because I'm sitting in the Greater Houston Partnership and very business focused, you know, the person that we don't have at the table is the employer. And so, you know, if we have a way to maintain the funding for social services and the employer is bearing that cost, they might be able to influence the structure a little bit more and influence policy a little bit more if we're able to really put dollar figures onto what does it cost us to have these issues, to have lost productivity, to have, you know, lost health, and then associate that with, okay, this is what it costs to fix it upfront versus after it becomes acute and chronic and it's at its most expensive point. So I don't know if making the case through small initiatives is the way to go, but I do think that it's, I forget who had mentioned before, it's an alignment of the interests and the incentives.
I mean, so I think part of it, there we go. I would sort of throw out there that when it comes to social determinants of health or non-medical drivers, depending upon who you're talking to, one of the things, for at least for me, that's important to keep in mind is it's upstream. And by being something that is upstream, it's going to have consequences and benefits for individuals and for particular illnesses and diseases downstream that might require a very particular medical or health intervention downstream. Upstream, there's an opportunity for us to do something that might feel generic and not necessarily targeted at any particular disease, but in fact have ramifications and benefits across the board. I think another key thing for us to consider as a culture and as a society is to try to correct and redefine what we think of as bugs to a system that we should address and what are features of systems that are in place. Because I think the reason for that becomes, and I appreciated you sort of pointing us away from the individualized treatment approach to think about this more from a systems level attack, is that when you place the onus on the individual, you are in some ways placing a blame, stigma, and you are saying this is something you did to yourself. Whereas I think that attributes health as some sort of a health outcomes as some sort of a bug. The reality is it's a feature of this system. And if we want that changed, that requires a change at the systemic level.
And just one more point, I think those are wonderful points. The other point I'll just make is that, number one, I think it's really important to piggyback on what you said, that we actually begin to just think about addressing social determinants and thinking broadly about holistic care as all part of the same, that we are not now kind of relegating that to the side. We are actually putting this front and center as a metric. So if you want to be a center of excellence for CKMH care, then you're going to be having people on the team that are actually assessing social determinants and actually working to address that by engaging people and connecting them with community resources. But that's just one small tip of that's the tip of the iceberg in that regard, because there's a broader question of what's happening in the actual society. And I think that that really is going to end up being a harder slog, and it's going to be a multi-stakeholder approach, because, as you said, we have differing incentives. The government has some incentives for certain things, employers have incentives for certain things, payers have incentives for certain things. The only thing that is going for us is that, number one, we know that this is not a high-cost endeavor to address some of these things. Some of these things are really low cost compared to what we're talking about with the GLP-1s. Some of these things are a drop in the bucket. That being said, I will say that we do need more evidence. We only have evidence for a couple of these social determinants, things that addressing that can have some impact on health outcomes. That's going to have to be a key question. What's the best way, the most effective way of doing that? And can we show that it actually has some at least intermediate term effect on health outcomes?
Hey, Charit, great talk. It's always great to hear you speak. But the presidential advisory has been a great initiative from AHA to highlight the problem of CKM. I've been, as you know, I've been working with a risk-based approach, and I love the idea of a targeted approach to prevention where you identify risk. But based on a lot of the work we have done, as well as others have done, I've noticed that it's not just high, low risk that matters. If you look at a cohort of individuals, majority of the events happen in actually low-risk individuals, because that makes the bigger chunk of the population, and that captures a lot of the individuals who are going to have risk. So, and those individuals, if you just take a risk-based approach using a Framingham score or PCE or PCPHF, they are often missed. So I think a lot of time what we have been doing in the recent times has been focusing on how do you identify those seemingly low-risk individuals that would be skipped by a risk score
Yeah.
by integrating like biomarkers
Yeah.
or EKG-based LV hypertrophy. And I think considering the PREVENT score is a great start as a
Yeah.
first tool, what are your thoughts on how do you integrate other more expensive screening strategies
Yeah.
into the risk stratification?
No, it's a great question, and I think so. So to your point, I think the question is how are we going to optimally identify where we're going to be targeting these therapies in the population? And the answer is I think we don't quite know yet. But as you have led amazing work in this regard, and I think at the end of the day, the things that we do know are that if we can identify those people who really have the highest absolute, who truly have high absolute risk, and risk scores are a starting point. Often we need to refine things in a way that says, okay, that's really who has high absolute risk, but that's where we're going to get the greatest bang for our buck in terms of absolute risk reduction. So there's no question that there are some things that improve discrimination above and beyond. The cardiac biomarkers like NT-proBNP and troponin are really helpful for people with coronary disease. We know, I think, CAC, we know that we see a lesser number needed to treat in those individuals who have some of that as well. So the question is where we're going to employ those. The reason they haven't actually made their way to PREVENT thus far is because they're not actually population-based strategies that are going to be accessible in the broader population currently. So people can differ in terms of how they think about the approach to what should be in a kind of official risk model. But I think that those things that you're describing have a lot of potential in the future. I think that, for example, incidental coronary calcium has a lot of potential in this regard. I think that the cardiac biomarkers have a lot of potential in this regard. And I also think that potentially things like the machine learning and other things could have potential as well. So I think this is going to be an ongoing question. The goal will be to see what measures can show that you can get the best identification of absolute risk reduction of individuals who would benefit the most from targeted therapy. So I think that's the goal, and I imagine your work is going to help to inform a lot of what we do.
I have a question for both of you, because I just don't want to get off this topic. CAC is obviously something that for us has become in a very, I'd say, well-employed community that we take care of. Almost a routine assessment of the patient. And when you look at what it takes away from a cost perspective, if you have, obviously in a reasonably priced coronary calcium score, you're avoiding cost if you don't have much coronary disease and you don't think a GLP-1 agonist is going to be of dramatic benefit for that patient from a CV risk standpoint, or even a statin, although those costs are minimal. What is the cost value right now for coronary artery calcium score as incorporating it in populations that don't necessarily, that if you can charge $25 or $50 for literally a 6-minute study, you can incorporate that as a routine assessment, even in populations that are not as well-to-do?
It's a very interesting question. And Ambrish, I'd love to hear your thoughts as well. But what I will say is two things. First of all, I think that, so for those of you who don't know, coronary calcification, if you have somebody and you say, hey, the same therapy, if somebody has a coronary calcification score of 0 versus a coronary calcification score of 100 or even better, 400, you see a dramatic difference in what the actual absolute risk benefit is for that person. The person with a 400 score, you're going to see a much lower number needed to treat to actually achieve benefit versus the people who have a CAC score of 0 who have a very low short-term risk. Now the question is, are you focusing on their short-term cardiovascular risk, or are we going to focus on their long-term cardiovascular outcomes? And that is an important paradigm question to think about. It has a lot of implications for cost, obviously, as we think about these therapies. So when and how are you going to employ this? So that's one question. I think the second piece that I would bring on board as well, the reason I brought up incidental coronary calcification is because we have a lot more people in the country who get CT scans for non-coronary reasons, who, if you look at their CT scans and retrofit them, you can find out what their calcification situation is using artificial intelligence. And that actually does seem to be very interesting as a potential mechanism for broadening the pool of individuals where you can think about where you're going to get the best bang for your buck. still raises the question of, those methods are still being refined, but it still raises the question of how much you want to focus on short-term versus long-term. But I imagine that's going to be a key part of the discussion for some of these agents that are very expensive for right now. Ambrish?
I completely agree. I think I look at CAC more as a really good opportunistic risk stratification strategy for people who have already had imaging for other reasons. If you are going to scan people just for risk stratification, then you have to really narrow down the population. Otherwise, it's not just the number needed to treat for economic standpoint that matters, it's the number needed to screen. So how many patients do I screen to get a CAC of 400 to treat them with statin to prevent one event? So you actually, if you have to screen 10,000 patients to find one 400 CAC, then you treat it and you prevent an event, that is not going to be economically viable.
Yeah.
So I think it's a really good strategy if you already have existing
you already
CT
have it.
scans and you just use that as a retrospective data point.
And also, the opportunistic approach actually makes a more diverse and representative pool of people who are included, because a lot of people go to a CT scan in the ER and other things like that, but the population you're talking about is often not the population that really reflects the real-world population. So,
And I'll just say that if I look at biomarkers, echo and CAG the same way, if I am going to get a test for an expensive test just for risk stratification, I need to make sure that I would not do the treatment just based on the risk factors. So if they're high risk based on prevent score, if they're high risk based on PCE, there's no reason for a CAC or a biomarker because I already know they are high risk. But if they are intermediate risk or low risk, and where me doing the CAC can make a difference in the risk assessment or up-risking the patient, and also if the conversation with the patient can be different, if they visualize coronary calcium, and they will be more willing to take it despite their low risk. That is in my mind, the Goldilocks population, which is low intermediate risk, but there is a potential reason to think about statins or other preventive therapies in there.
I mean, when I see the numbers of poor use of risk-reducing therapies like statin therapy, a lot of times it's not that the doctors don't want to give them. I mean, there's a lot of statin resistance out there. And the calcium scores a lot of times help us say, look, right now, your calcium score is 0, you're okay. I mean, from a population standpoint, it's a different animal, but on the individual level, certainly it does impact how aggressively you treat someone depending on the finding.
and that's why we have this complementary staging approach where subclinical disease is part of that kind of concept, and also the risk scores are part of that concept. I think those two things are going to, as Amrish described, be complementary in helping identify, okay, where are you really at high risk, and helping with that discussion with patients to understand where lifestyle alone may not be sufficient.
I'll just add one last point since Khurram is not here, so I can bash CAC a little bit. So CAC of 0 is informative if your clinical risk is low. If your clinical risk is high, if your PCE score is 20, CAC of 0 will still give you a high enough risk, because CAC is more of a short-term risk, but your long-term 30-year risk is still going to be substantially high if your LDL is out of range. And so CAC of 0 is really helpful in low intermediate risk patients for de-risking. But if your PCE is high, and you can look at Khurram's paper in JACC, the risk goes up as your PCE score goes up. And so I think that decision-making is also important.
The impact of 0 is it blunts the risk factor increase, the cumulative effect of risk factors. Salim? It's unusual to have the luxury of these three luminaries together.
I don't know how many do you need here to bash CAC of 0, but I mean, I think Khurram should have been here. No, I think even if you look at the guidelines, it's very clear. We're having this discussion about CAC 0 when we're talking about GLP-1s and SGLT2s. Actually, if you look at statins, it's very clear data. CAC 0 is not event rate of 0, right? And statins are now, I mean, they're dirt cheap, right?
Yeah.
So the only analysis where a CAC-based approach, and I think Khurram should be here so we can have a little bit of a back and forth. The only analysis where CAC 0 as a population level strategy works for statin therapy is when there is clinical disutility on the part of the patient. Otherwise, $4 generic medication for statin, actually any analysis you look at right now, it works. The thing is, if you have a risk, 10-year risk of 3%, 4%, you have to treat a lot of people. But if the patient is okay taking it, a therapy that's generic and it's very cheap, it works. for GLP-1s and SGLT2s, I actually think it's a very important point. What are you treating? If you're treating short term, sure, go ahead, use an approach that is based on CAC. But if you're actually looking at long term, I would be very careful, because what you're doing, if somebody has 3 risk factors and you're doing a CAC-based approach, by guideline, if you actually are very true to yourself, you are saying, I'm going to repeat a CAC again in 3 to 5 years. And how many times does that happen in clinical practice? It doesn't happen.
It depends
And
on your
that is
practice,
my
you're right.
concern, that you're going to miss a lot of people, especially now that the focus is actually moving towards treating these people very early on, where you can have a ton of risk factors,
and
but may not have CAC. So I think those are, as long as those nuances are realized, I think it's a very good approach, but those 2 nuances have to be realized by the clinician treating the patient and the patient as well. It's not like CAC 0 means no events, it means fewer events in short term.
I've had them. I mean, in 5 years, I repeat them, they go from 0 to 250, and it's because the patient did not want to be on statins. So.
I'll just add that for cardiometabolic therapies like SGLT2 and GLP-1, the value of CAC goes further down because they are helpful for heart failure risk reduction, CKD risk reduction, and CAC doesn't predict as well heart failure risk and CKD risk. There are so many younger obese individuals that have a high risk of heart failure in the short term with HFpEF that you would miss if you're using CAC to implement CKM therapy. So I think CAC is a great marker for CHD, coronary heart disease, but if we are thinking more global and CKM prevention, I think a score like PREVENT that is more all-encompassing for different risks is much more informative a tool than a single biomarker like.
Well, there's so many different ways of thinking about it. I know we have to go here, so I don't want to prolong too much, but there's a short-term risk, as you said, versus long-term risk. But then even how are you going to define that? So if you want to look at the 30-year score for individuals and you say, okay, you have both a low 10-year score and a low 30-year score, then probably in that scenario you say, okay, maybe that's where not prioritize. But if you have a low 10-year score, like almost every young adult does, but a high 30-year score, is that a scenario where you say, hey, we're going to get multi-system cardiovascular kidney metabolic benefit and think about starting to treat those now so that we don't find ourselves with a CAC of 400 by the time they're 50 in that scenario. So I think it's a very interesting question of what you're treating, how you're treating it. Also recognize that these are moving targets, and at the end of the day, today this is the discussion we're having. In 10 years, when these become generic, maybe the discussion is going to be a little bit different. Certainly already different for some of the SGLT2s that are now starting to become more generic. So it's a very interesting question. I think this is going to be a very interesting paradigm, but we are going to have to prioritize in some way, shape, or form who's getting these therapies. If we gave everybody right now in the population who was eligible by virtue of BMI and having some metabolic risk these agents, we would literally spend more than total healthcare spending just based on that alone. So that's obviously not going to be a viable approach, but the question is going to be, how are we going to do that in a way that's evidence-based and equitable as well? And also right now, the discussion is, as was being said by Salim, is shifting earlier and earlier to pediatrics. The AAP guidelines have talked about now in this high-risk young adolescent who comes in with early onset diabetes. Do you ignore that with the obesity, or do you start thinking about treating more aggressively early because of the long-term health consequences? So this is a really challenging discussions, but important ones because they reflect where our society is.
Thank you. I appreciate the conversation. Luz Garcini, Interim Director of Community and Public Health at the Kinder Institute, work together with Dr. Potter. And I'm also a clinical psychologist. And I think one of the things that we don't hear here is a lot of behavioral health. And I think that's where, when we can identify these risk individuals, right? We work a lot with historically marginalized communities. They don't want the medication, because of many reasons. Their own beliefs, they have other ways of addressing it. It's expensive, they're uninsured. And I think if we started to talk about addressing some of the social determinants of health, adding the component of the behavioral health that can help a person understand the systems and empower them to fight those systems, to become self-advocates, to empower them to advocate for their community and change those systems, we have a better chance.
Yeah, I think that the behavioral component is a core component. So if you talk to people in communities where these challenges are occurring, they actually, and you talk to patients, they will say, what's not being addressed is my psychosocial health. What's not being assessed is my sense of agency and my ability to actually feel like I can overcome daily challenges. What's not being addressed is these barriers to activation to engage in healthy lifestyle above and beyond the actual real social barriers I'm facing. So that's important. The way I conceptualize it is part of the package. I don't think that it means that because you have those barriers, that means you can't have a medication. I don't think everybody needs a medication either. I think it just needs to be part of the package. But to your point, it's highly, highly under-recognized and under-addressed. So as part of the integrated team, we very much actually advocate for the idea of behavioral and psychiatric involvement on that team. And we also discuss the fact that mental health disorders are a risk enhancer for progressing along this CKM syndrome progression, to exactly your point.